Make sure this goes through. Drop that box for you.
This is the one. Yeah. All right. Thank you very much, and thank you for the kind introduction. So I'm going to talk a little bit about medication-assisted treatment for all substance use disorders. I'll touch on opioid use disorder, but oftentimes we think about, there's a lot in the media right now about MAT, and we think about buprenorphine and methadone, but there's actually a number of different medications that fall into this category.
Did it get stuck?
And yeah,
I don't know why. That's
that one.
Now it should work.
So actually, the way it is defined federally, it's the use of pharmacological medications in combination with counseling and behavioral therapies to provide a whole patient approach to the treatment of substance use disorder. So we talk about MAT and we think about medications, but the idea is that a MAT approach includes both medications and the therapies. And there has been a lot of research. So the big one is that most MAT, most medication-assisted treatments, improve mortality. So they are associated with improving lives saved. In general, when we look at outcomes, when you look at providing treatment with MAT versus just regular treatment, you have much better outcomes, and we'll go through them. And so really federally, it's becoming a best practice. People who receive MAT are less likely to need inpatient detox and rehab. For people with opioid use disorder, that they're less likely to overdose and again, to stay alive. Also, people who receive MAT are more likely to stay in treatment programs too, and more likely to complete the course. They're more likely to function well. So they're more likely to be employed or go to school and then report that they're connecting with their family. Also, MAT is associated with reduced risks of infectious diseases like hepatitis C and HIV. And then a big thing actually is that people who receive MAT compared to treatment as usual are much less likely to have reinvolvement in the criminal justice system, much more likely to not be reincarcerated and have legal charges. So MAT generally it's a treatment approach. It can be provided either in an inpatient setting or an outpatient setting. And ideally, we would like to see MAT in in one-stop shop places where somebody comes in for healthcare and they can get counseling, they can get medical care, they can get substance use treatment, and then also get connected to vocational resources, educational resources, and social services. So I mentioned sometimes we think about MAT just in terms of opioid replacement therapy, but we have good evidence for MAT as a treatment for nicotine use disorders, so smoking, for alcohol use disorders, and then also for opioid use disorders. Most of the time, MAT can be prescribed in an office setting, so it doesn't have to be a specialized office, it doesn't have to be a hospital setting. We'll talk a little bit about the difference between methadone maintenance. That can only be prescribed in what's called an opioid treatment program. And MAT can either be short-term, so just sometimes a week to sort of help somebody detox, or it can be long-term in years. Yeah?
I have a question. So it's Matt Tandy, Oakland Police Department. If you're going to answer this later, you can just tell me,
No,
shut
go
the
ahead.
face. If we, as officers, are talking to somebody and they're in a medication-assisted treatment program, how do they normally refer to it? Do they say, I'm in MAT, or is there any common language that they use?
It will probably be different for each person. So sometimes they'll talk about methadone. Sometimes they'll talk about the medication itself, buprenorphine. I mean, it can be as simple as a nicotine patch. So they may not even think about describing it as MAT.
Right, okay. So they might actually use what medication they're taking.
Yeah. No, that's a good question. So what we know generally is, again, it's despite the fact that it's so effective, we tend to not use it very much. So when you looked at the 2.5 million people with opioid use disorder, less than 1 million were receiving MAT. And then actually when you look at substance use treatment programs in general, fewer than 30% are actually prescribing MAT. And then again, of the people in those programs, 50%, less than 50% who actually could have benefited from MAT actually receive it. So there's a big federal push right now to increase MAT. So a lot of times when you hear about the term MAT, you're right, it's not from people actually receiving it. It's sort of more from policymakers and treatment agencies and government papers.
Why would treatment programs not use medicine?
A lot of it is because you have to have a prescriber. So a lot of times treatment programs don't necessarily have physicians or nurse practitioners or people with prescribing authority.
Now that I don't need a license to do that in the state.
Right.
Good.
Yeah. Yeah, we can increase that.
I'm going to call in some prescriptions.
I think the other thing is there's a lot of stigma too. So, a lot, and we'll talk, so some of the mats like methadone and buprenorphine do act on the brain in a similar way to opioids. So you do hear a lot of worries about substituting one addiction for another, because there are some forms of mat where you do have some physical dependence. Nicotine replacement is another one like that. And so sometimes you have some strong beliefs around abstinent models and abstinence working best. I think a lot of times substance use disorders are hard to treat too. And so even though the outcomes are generally much better with MAT than without MAT, still not everybody gets better. Sometimes it will take several times in terms of seeking treatment and being able to stay engaged. And so sometimes people get disillusioned about it. We'll talk about the different kinds of MAT. Some of them you do have to have specialty prescribers. So buprenorphine, methadone maintenance is also very regulated. And again, I think just in general, amongst people seeking treatment, among providers, amongst people referring treatment, there's a lack of understanding about what MAT is. And so that was actually part of the reason why we were having this presentation too, just to kind of have everybody sort of on the same page about what MAT is. So MAT for opioid use disorder. So there's really two different categories. So an opioid antagonist treatment is a medication that works on the opioid. We all have opioid receptors in our body and in our brains. And an antagonist treatment is a blocker. So if you receive naltrexone or naloxone, it actually blocks that opioid receptor. So you can't actually feel the effect of if you were then to ingest more opioids. So a blocker just sort of blocks it, means you cannot get high off of heroin or off of the prescription drug if you take it after the blocker. The agonist therapy, methadone and buprenorphine, they actually act on these receptors, and they stick to the receptors. So you can't then take more, if you take more heroin or more prescription drug, it actually doesn't do anything because you've already got a compound on that molecule in the brain. But this is where methadone and buprenorphine are a little bit like other opioids. So you still feel some of the effect, you still feel, and you can become physically dependent on these if you take them every day. And so they work very differently. The blockers versus the agonists work differently in the brain.
Where does Suboxone fit?
So buprenorphine is the generic name for Suboxone.
Okay.
So as I mentioned, methadone maintenance can only be prescribed in opioid treatment programs. So these are clinics, they're often called methadone clinics. They're highly regulated. They require federal certification and state certification. And then, but these clinics can provide, they generally treat opioid use disorder, and they can provide methadone LAM, which is another methadone-like compound, buprenorphine, or buprenorphine with naloxone. And OTPs, they prescribe the medication, and they also need to have access to counseling services. So methadone maintenance treatment is provided at OTPs, and it's a multi-component treatment. So methadone, actually, when we look at all the different medications or MAT versions that we prescribe, the most research and the most study that we have is actually done on methadone because it's been used successfully for years. And actually, when we look at the outcomes with the criminal justice system, methadone actually has the most robust research showing that people who are on methadone long-term are much less likely to be reincarcerated, much less likely to have legal charges. So people receive methadone there. They also receive some substance use counseling. Methadone clinics are also required to provide HIV testing and Hep C testing and some coordination of care. A little bit of vocational training to help people get back into employment, and then sober living supports and connecting with NA and AA. And I think the difficulty with methadone, the opioid treatment programs in a rural state like New Mexico, though, is that you get some communities and some counties that just don't have access to an opioid treatment program. And so these are often places where you do need to pick up your dose daily, and it's just really, it's logistically impossible for somebody who lives in a really rural community to drive to an OTP several times a week to get their treatment. But for people who do well with that methadone maintenance treatment, it can really be a life changer. So it was approved in 1972. It's a long-acting synthetic opioid. So it blocks the euphoric and the sedating effects of other opioids. So once you take methadone, and then, as I said, if you take heroin or you take OxyContin, you really don't feel it. That those other drugs can't kick off the methadone that's already on the receptor in your brain. It also relieves opioid withdrawal symptoms. So as you know, people who are withdrawing from opioids, the withdrawal is excruciating and it really feels unpleasant. It's, you're feeling nauseous, you're feeling, you get diarrhea, you get shaky and cold-like, and it really feels unpleasant. So a lot of times, being able to start methadone right away you don't have to go through that experience. When you take it long term, you take it daily, you develop tolerance, so you don't actually get euphoria or intoxication each time you take your methadone dose. So people on methadone maintenance really can live a very normal life. As I said, that we've got a lot of research showing that people who are on methadone maintenance have a reduced risk of acquiring transmitted disease that are acquired through injection drug use, like HIV, hepatitis, or endocarditis. There's actually reduction in kind of sexual risk-taking, very strong outcomes in terms of reduced risk of mortality and dying, reduced criminal activity, improved stability with family, improved engagement in employment, and then also for women with opioid use disorder who are pregnant, much better pregnancy outcomes in terms of healthy babies and staying connected and being able to stay, have the baby continue to stay with them and not involved in foster care. Buprenorphine or Suboxone. The advantage to buprenorphine is that you don't have to receive this in an OTP or a methadone clinic. You can receive this just at your family doctor or at a regular clinic. It also reduces the ability to get high after opioid use, and it reduces cravings. And again, a lot of good data that it helps people return to normal activities. Like methadone, you do get physical dependence. And so these are medicines, you take them every day, and then you miss a few doses, you will go through withdrawal. Buprenorphine is a little bit safer than methadone because you're less likely to it's less likely to cause respiratory depression. So if you take an overdose of methadone, your breathing slows down so much that you can die from not getting enough oxygen. So buprenorphine doesn't cause quite as much slowing down of your breathing system. There's also fewer interactions with other medications. So I mentioned clinicians can prescribe this in a regular office setting, but they do have to go through some extra training to get a particular license to prescribe buprenorphine. You can either use it for withdrawal, so somebody who's going into withdrawal, you can prescribe buprenorphine for about a 5 to 7 day course so that they don't go through that withdrawal, or again, you can take it for years as maintenance treatment. And what we know is that some of the outcomes in terms of kind of re-engaging in family life and in work and reduced criminal involvement are much more effective if you actually get long-term maintenance treatment and you do take it for months to years. So the data, the Drug Addiction Treatment Act 2000, this is the law that was passed to allow buprenorphine to be prescribed in office settings. And so you either can be a physician, a nurse practitioner, or a physician assistant. And I think there's just some legislation out now allowing nurse midwives to also prescribe buprenorphine. And then either you need to have an addiction certification or you take this additional training 8 to 24 hours and specifically around treatment of opioid use disorders. And that's called a waiver when the clinicians have that extra training. So physicians, it's an 8-hour training. For PAs and physician assistants and nurse practitioners, it's 24 hours. And I think the nurse midwives, it'll also be 24 hours.
Did that say psychiatrists don't need a special license?
If you have addiction psychiatry boards.
Oh, addiction psychiatry.
Yeah. And then also as I mentioned, MAT is the medication, but it also includes the psychosocial counseling and the therapy. And so when clinicians get these waivers, they also have to say, yes, I have the ability to either provide therapy in my practice or I can refer to someone. So that everyone who's prescribing MAT or buprenorphine also needs to be able to refer to psychosocial services. They get a unique DEA, and then And then also that it's very regulated by the DEA. So you do have to maintain a list. And so when you prescribe, the DEA comes out and makes random audits. So I've had them come out to visit me and make sure that all my paperwork is in line. And so when you first start, you can prescribe up to 30 patients a year. And then now it really has increased. You can go up to 100 patients, therefore. And actually with the special permission, you can go up to 275. So naltrexone is another kind of MAT for opioid use. It's for opioid use disorder and alcohol, and it's an antagonist, so it really blocks the receptor. So if you're given naltrexone, you actually don't feel much. So you don't feel high, you don't feel anything. But what it does is it blocks the euphoric effects of opioids and alcohol. So if you take naltrexone daily and then you either take heroin or you take OxyContin or you drink and get drunk, you actually don't feel much. And so it starts working because people just don't feel the effect of the drug or the alcohol that they're using. The other thing is it blocks some cravings, especially in alcohol use disorder and opioid use disorder. If somebody has a lot of opioids in their system and you give them naltrexone, they'll immediately go into withdrawal because it's kicking that receptor, the opioid off their receptors. And it can either be available in a pill form, you take the pill daily, or 3 times a week in a higher dose, or you can receive a monthly injection. And so there's a lot of actually interest in using this and kind of actually in the criminal justice system and in jail settings or in prison settings, because it's not diverted. People don't end up sort of selling it for street value. The difficulty is that when sometimes you're out of that either probation setting or a jail setting, people don't come back for treatment. And it's not because it's unpleasant, it's just, most of us don't fill our antibiotics or finish all our medications. And because you don't feel anything when you take it, it's actually hard to kind of either to commit to going back for your injection or commit to coming back and taking the pills.
I have a question on this, and I don't know if you'd be able to answer this, but you were saying that it kind of, if someone is taking this and then they use a substance like alcohol, it doesn't have the same effects.
Right.
What would this look like to us in law enforcement if we were out with somebody that had been drinking a lot but taking this? Does it not change their fine motor skills and things?
No, that's a good question. So yes, the alcohol will still affect their fine motor skills, their coordination. I mean, they're still not safe to drive if they're intoxicated. But getting drunk just doesn't feel as good. You don't feel that. So it's
not like they're using this to try to have a DWI get away with it.
Right.
It's not like you take it and all of a sudden you're sober and you can pass it.
Right. No, good question. Yes. Yeah.
Because right when you said it, I was like, I don't know how people aren't abusing that more frequently.
Yeah.
Like, oh crap, I'm getting pulled over. They just take it.
Yeah. No, if only we had something to reverse intoxication. But no. And then naloxone is sometimes talked about as MAT. It's really different from MAT. It's not a treatment. So as you know, naloxone is given for opioid overdose. It reverses the respiratory depression. It's not a controlled substance. But again, and so it's sometimes called MAT as a category. I don't think people themselves, you're right, would ever think about naloxone as MAT, but sometimes these federal documents include naloxone as MAT because it really is a medication-assisted treatment to help to address substance use disorder and to help get people into treatment. Well, we do try to encourage everyone, all healthcare providers, when working with folks with opioid use disorder, is to kind of look at all the medications they're taking, really ask them about their substance use history. There's some screening instruments we recommend. We encourage providers to check the Prescription Monitoring Program, or the PMP, and that's now state law in New Mexico. And so this is, if I was going to prescribe a substance that's controlled to a patient, I need to check this database, and I need to make sure nobody else is prescribing so that they're not diverting it, they're not selling it, they're also not getting multiple prescriptions from multiple providers, to take an overdose history. Also, as we prescribe these medications, to really educate patients and families about overdose, offering naloxone rescue kits. And then for people using needles, either referring them to needle exchange programs and then discussing how to safely dispose of medications too. So we're taking a harm reduction approach. So I'm going to move on to MAT for alcohol use disorders. But any questions about MAT for opioid use disorders before I go on?
What questions from the network? As people type this in, I just have a quick question. If you could talk a little bit more, because you were just talking about a harm reduction, so safe needle exchange. Are you saying that like these, methadone treatment centers and places where people can go, they don't offer a needle exchange in-house there?
Not usually in-house. So usually, but usually it's nice for them to be able to connect to the other needle exchange programs too, so that they can connect people. But most of them don't. It's not a federal requirement, and most of them don't offer needle exchange in-house.
So if someone is using or getting treatment with methadone or Suboxone, and then if they apply for a job that requires a drug screening, will they fail that drug screening?
It's a good question. It will depend. And so not all buprenorphine or Suboxone don't show up at all drug screenings, and methadone doesn't either. So not necessarily. It depends on what drug screening that the employer is using. And again, it's sometimes better to be transparent than not. And again, the person prescribing it can always write a letter saying, that we expect this and we're prescribing this, and and again, because we do know that people who are actually on chronic or long-term MAT do better and actually stay employed and do well. Unfortunately, I think there's still a lot of concern and a lot of stigma still.
And then I don't know if you're going to cover this later, but the medications you just spoke about, are you going to go over if they're misused or how?
And so I can. So both and so that's the big difference between the agonists and the antagonists. So the agonists, which are the ones that kind of really do act, they're opioid-like substances. So the methadone, the LAM, and the buprenorphine or the Suboxone can be misused. So these are the worries. They can be diverted. If you don't take them regularly, they do get you a little bit euphoric. They do have street value. Buprenorphine, the reason why it's office-based is it's a little less likely to be abused, but it can be. And you can cut things up and you can mix them up with other medications. The naloxone is less likely to be diverted and abused. And so that's why it doesn't have as good outcomes, because people are less likely to stay on it, but it's also less likely to be diverted.
Do you know how? So with methadone, we'll see people carrying with like little jars on it. If someone is misusing it, is it just, how are you guys seeing that? I guess I should say, is it just in unmarked jars? Or on the network, have you guys seen it? I know when we had a lecture on Suboxone, later we were talking about seeing it in custody. People were cutting it up, I guess, in the jails and trying to do stuff. But have you guys seen this stuff abused or sold, and what does that look like? I know, Sergeant Moriarty, I think check your mic again.
Okay.
There you go.
Can you hear me?
Yes, sir.
I was going to let you know, in Chicago, it's always in an orange tablet, and you're going to see it almost like in a film case, and that's how it's diverted based on milligrams of dependency and where someone is in their recovery. And most of the time they take it with you, and they kind of they'll give you up to a week, and that's why you'll see it constantly. You'll see it. It's common to be resold on the street.
Interesting. Because this is something that we're seeing, unfortunately, more and more in law enforcement. We're hearing about it. And there's a lot of misunderstanding, I think, on our end.
What do you see here?
I think both. So we had a presentation about Suboxone and some myths, and what was kind of presented there was that you could not actually get high off of Suboxone. And then everyone's like, well, no, we're seeing in custody people are cutting it up and doing that. And so the presenter that time was making it sound like if you were to cut it up and it had almost like Narcan or naloxone in it somehow that did it, but people are, maybe they're not getting high, but people like to get high, so they're doing whatever.
People are clever, and it's, and so that's the idea. Naloxone, there's two different forms of naloxone. So naloxone by itself, it was the way it was originally prescribed, and people were cutting it up, and they were cutting it up and heating it with benzodiazepines and kind of creating a concoction, and that was associated with some overdoses. For most of the Suboxone that's prescribed in the United States, it does have naloxone in it, so it's a little harder to do that, but people are clever. And I do think it doesn't get you really high, but if I don't have any opioids in my system and I take some Suboxone, I'll feel a little high. So it's got some street value. I've heard in the jails too, because like you can either take it as a pill, but there's also a film. And I was hearing that people were putting the films in the letters that they were writing, and then people were licking the letters and getting, and it's maybe not the best high in the world, but it's again better than nothing. The Suboxone that's prescribed to pregnant women doesn't have naloxone in it too, so that's just pure naloxone. So that is pretty abusable. Bridget, you sound like you're like you have some.
I was just wondering about methadone here. The methadone clinics that I worked at in New York are all liquid methadone, which is harder to.
A little bit harder.
Sneak out.
Yeah.
I don't know if you guys are all doing pills here.
Yeah, people are clever.
But once you get on, I mean, you're like, if you're coming every day to get your methadone, it's harder because they're watching you take it every day. But once you have a good rap sheet there, then you get like less days that you have to come and pick up. So
they'll give you like a 3-day supply if you just take it with you.
So.
Just asking for a friend. God, that's so hard. It'd be hard to stay in treatment for this stuff.
Yeah. The other piece, interesting, Suboxone too, there's a street value for people who can't get into treatment, and then they take it as a kick pill. So people who are using, they really want to get off. They don't want to go through withdrawal. There's also a market for it to be used actually as a treatment. So people will pay, street value because they can't get into a waiting list into a Suboxone clinic. And so anecdotally, I've heard it's almost kind of half a one, 2 dozen the other, that they're using it both to stop.
How successful is it to stop like that, using it? I mean, are people successful using that to stop?
Yeah.
Cold turkey on that?
Yeah.
Interesting. Niels, I want you to let us all experience this. I know you're a Suboxone provider.
First, you have to go get some heroin.
This is preventing me from doing it.
All right. Any other questions around opioid use disorders before we move to Matt for alcohol use disorders? So Matt for alcohol use disorders is incredibly underutilized. So it's there's a lot of good data, and most people actually who come in with alcohol use problems don't get offered Matt. And again, it doesn't work quite as it's definitely better than no treatment, which is part of the reason. We'll kind of talk about the pros and cons, but it's certainly one that in general is just not as utilized, and it doesn't get taught in medical school, and people just aren't aware about it. So naltrexone, again, that same medication that's used for opioid use disorders, is also helpful for alcohol use disorders. So again, if you take, you can either take that monthly injection or you can take the pill every day. And if you relapse with alcohol, you just don't feel as drunk and you don't feel as euphoric when you're drinking. And so there's very good data that if people who are really trying and committed to reducing their alcohol use, if they take naltrexone every day, they're much less likely to have relapse, and they're much less likely to, and if they do relapse, they're actually going to have fewer drinks and get less drunk. The main limitation really is adherence too. So it's, again, you're taking a pill every day, it doesn't make you feel any different. And so it's just hard to take medication consistently for everyone. I think the other thing too is that if you are taking an opioid for chronic pain, again, it'll kick that off too. So people with chronic pain who are prescribed opioids aren't able to take naltrexone for alcohol use disorder. The other medication, the one that's best known probably is disulfiram or Antabuse. So this is the one that you take every day, and then if you do drink, you will get really sick and you will vomit because it interacts with the alcohol. And so and again, this actually can work for people who are they just feel like their alcohol use disorder is so difficult, and they've tried everything, and that this is really sometimes something that they and their partner will agree that they will do this together, and this is a way of committing to staying sober. And so I've worked with people who've actually really used Antabuse very effectively. The trick is you really want to make sure you don't drink. And so you don't want to get into a situation where you've taken it that morning and then you do make yourself vomit because you can't say no to the alcohol when it's around. The third one is a camprosate. Again, all three of these really don't have an abuse potential, which is in their favor. A camprosate reduces the cravings. So again, you don't feel much when you take it. But for folks that are taking camprosate daily, they're less likely to have alcohol cravings. And again, they're less likely to drink alcohol compared to people who are just in therapy or just in 12-step groups. Again, a camprosate actually is pretty big pills. There's 2 pills that you take 3 times a day, and they're horse pills. And so some people just don't like taking it. I've had other folks that I work with who actually kind of like it because alcohol has been such has been such a problem for them for so long. And so 3 times a day, they're actually also kind of committing to themselves, I really am going to stop drinking. I'm making this commitment. It's actually sometimes taking those 3 times a day tablets helps them commit to staying sober. And it also has this biochemical effect too, where it reduces the cravings. So that was Matt for alcohol use disorders, yeah?
Rahul Vasredi, UNM. How does acamprosate compare to gabapentin for reducing alcohol cravings?
I don't think they've been compared to head. I actually think there's more robust evidence as far as, because I think camprosate has been FDA indicated longer, so there's a little bit more evidence around time to relapse, and then when people do relapse, fewer drinks and fewer intoxications. There's a little bit better data, but again, each person kind of will feel it differently too. So, I mean, I've certainly had some folks that have taken a camprosate and they're frustrated because they take it faithfully and they still have cravings too. So if somebody told me that they actually felt better with the gabapentin, then that would be the choice I'd go with.
If someone has both alcohol and opiate, do you mix and match these medicines?
So it depends. I mean, so you can use if they're staying sober from both, you actually can use the naloxone because that'll be effective for both. If somebody's continued to use opioids but wants to maintain sobriety from alcohol, then you'd probably use a camprosate.
So I have a question. This is Matt Say of the Elk Creek Police Department. There's a lot of literature indicating that substance use, especially alcohol, in law enforcement is high. Mm-hmm. This medication that is presented, because most law enforcement agencies have relatively good insurance. Mm-hmm. How much does this cost by insurance, and is it normally covered?
So that's a good question. Naltrexone tends to be covered, and it's been around longer. A camprosate, it's increasingly covered. A few years ago, it wasn't covered, and it was kind of expensive. I think now with this push towards MAT, there's more evidence and there's more coverage for it. It's hard to I don't know the different kind of private insurance companies, and everything is a little bit different. But again, the advantage of a camprosate is it will not show up in any drug test, too. Neither in anti-abuse and naltrexone may, depending on the drug screening that you're taking. But a camprosate and disulfiram, if you take those will never show up on an employment screening.
If someone's on anti-abuse and the cops go out there and then they had a drink recently, and they're vomiting and their blood pressure's going up, is this a medical intervention? Should they call for ambulance?
I probably would, to be on the safe side, yes. And so, and again, we tend to prescribe anti-abuse in low enough doses that it actually shouldn't be a medical emergency. So when it was first used, 20 years ago, people actually had really high doses of anti-abuse, and then if you drank on them, it really was a medical emergency. It shouldn't be the low dose, but you never know how much somebody's taken. And so I think if somebody's intoxicated, appears in medical distress, it's probably safer to consider it a medical emergency. But yeah, I think again, alcohol use disorder is very, very common. And I think it's just helpful for people to know and family members to know that there are these medications out there to ask your physician about too, if that's something you're considering seeking treatment. Because they really, apart from taking a pill every day, you don't really feel it. And it can make a huge difference in somebody's life.
So this is something you can get from your primary care.
Mm-hmm.
It's not, you don't have to go to a specialist.
You do not know, but again, your primary care may not be as familiar with it, but they can look it up and they can ask for advice.
So Niels, I don't know if you know this question, but Carly was stating that the previous one, the N one,
not sure.
may come up on a drug screen. Mm-hmm. If we had an officer that was seeking treatment, that wasn't affecting their job. Mm-hmm. So they privately sought this and they had this as a script. they'd be fine if it came up with a drug screen,
I would think so.
right? They would just show, oh, I have a script for this,
Yeah,
this is why.
Yeah.
Okay. I just want to make sure that no one's
Trying to
scared.
take care of
or have-
myself and change my life for the better. Yeah.
Right. Well, I think that's a fear that some people have. It's
Yeah.
like, oh, if this comes up, then I'm not going to take it because I'll lose my job.
I didn't even know it came up on it.
Yeah, and most of them will,
What would it come up
it
as?
really wouldn't. I mean, my guess is most of them wouldn't come up. Drug screens could theoretically test for that. They can't test for the other two.
Okay, but it wouldn't come up as like opiates and be like,
No.
no, I'm on Naltrex.
No.
Cocaine, that's so weird.
Yeah.
That's my
Why
Flintstone.
there's never been a monthly for antabuse, like a shot?
I think because people change. And so you might be really committed May 1st, and then by May 28th, you've wavered and it's still in your system and it becomes
Medical
unsafe.
problem.
Yeah.
This is Melissa Schultz, APD. I just think it's important to point out that alcohol withdrawals can be deadly, and so you may need medical treatment excuse me, from what I understand, you would need to be honest with your doctor about the withdrawal process prior to just starting complete abstinence, even using naltrexone or antabuse. Is that correct?
That's a really good point. That is very true. And unlike opioid withdrawal is really dramatic and unpleasant, but it tends not to be life-threatening. Where alcohol withdrawal is life-threatening, and absolutely, if anybody's seeking treatment, being honest and transparent. And actually, it's interestingly, most of the studies that we show when people come to the clinician and say, "Look, I need help with alcohol, and I'm drinking X amount a day." Most people are actually pretty accurate in how much they're saying. They don't tend to lie when it's sort of one-on-one.
But with that in mind, do you prescribe benzos if someone's a heavy drinker and you're starting something like this?
Yeah. Yeah, so there's medication. So if somebody comes in and they're at risk of withdrawal, there's medications that we can prescribe to help somebody get through that period safely. Any other questions around that for alcohol use disorders? And so Matt for smoking. And again, this is, it almost also sort of helps to destigmatize, because nicotine is actually just as addictive as opioids too. And so sometimes it's actually just as hard to get off nicotine as it is to get off opioids. But because it's a legal substance, sometimes we don't have as much stigma around it too. But really kind of biochemically, Matt for smoking works very similar to Matt for opioids.
When you were going through this one, would you be able to identify, unless it is just the same, the difference between smoking and other tobacco use, like dipping and things like that? Or do these work across the board for all of that?
They work across about, yeah.
They just
it really
refer to
is.
as smoking? Okay.
Yes. And so, yes, you're right. And we do talk about smoking cessation, but they help for dipping and then also vaping and everything else that people are using.
Oh, vaping. Forgot about that.
Yep. So there's really three different kinds. There's nicotine replacement, Chantix or varenicline, and then bupropion or Zyban or Wellbutrin. And nicotine replacement are the lozenges and the patches. And really, this is actually very akin to taking buprenorphine or methadone. This is nicotine that you're taking in a very controlled way. You're taking it daily. And it prevents the urges and cravings for more nicotine. And again, especially if nicotine replacement is used in conjunction with counseling and therapy or group support, there's good evidence that it does really help people stop nicotine use. Chantix is a tablet that you take every day, and again, it reduces the cravings for nicotine. So it's sort of more akin to the acamprosate or the other medications that we're talking about for use with alcohol. And then bupropion or Zyban or Wellbutrin, it's interesting, it's an antidepressant that also reduces cravings too. So for folks that are taking, want to stop smoking, but also maybe have some anxiety and depression, this also can be a nice option. But it's also prescribed for people without depression who really just want to stop smoking, and you take it twice a day and it reduces the cravings. And again, people who, if you compare people who just sort of quit cold turkey versus people who quit and then use a medication for nicotine replacement or a medication to help cravings, do actually have much better outcomes and are much more likely to quit and to stay quitting. just generally best practices. Everyone should be screened for, when people come in for healthcare, the idea is actually we should be screening everybody and asking and just normalizing it too, so that we ask everybody if they're having problems with opioids or alcohol or nicotine. And then if people do either acknowledge this on a screen or ask for help, the idea is to do occasional drug screens. We do use patient contracts, especially for the ones that have an abuse potential or diversion potential. We encourage all clinicians to check the prescription monitoring programs. They have a good sense that people are getting prescriptions from other providers. And then again, all kind of office-based care too should either be offering counseling or psychosocial services or be able to refer to other agencies or other clinicians.
Could you give a brief on what a psychosocial service would be?
Sure. So it can either be one-on-one therapy and helping somebody think about kind of their motivation for change, or practicing relapse prevention. Sometimes we do things like, role playing, how to say no. So if you know that you tend to drink when you go to the balloon fiesta or when you go to friends, what are you going to do? How are you going to strategize? So sometimes a therapist or a group will sort of role play situations or think about situations with somebody about how to prevent relapses, how to say no, how to decide how to anticipate when something might be tempting. Sometimes also, things like cognitive behavioral therapy too. So sometimes people use because it's associated with depression or anxiety. And so thinking about, oh gosh, most of the times you've relapsed, you've been really depressed about something. And so doing some therapy around depression. So those are some of the examples of psychosocial interventions or therapies for substance use disorder. These are a couple, again, the idea we're really trying to encourage most healthcare agencies, and I think actually sometimes in correctional settings too, actually to do sort of standardized screening. So that idea that actually it's not like we can kind of walk into a room and sort of pick out, oh, you might have a substance use disorder, and I'll ask you. But actually all of it, substance use is actually incredibly common in the United States. And I think sometimes we don't, we'd be surprised about how many of us actually do have substance use problems or have family members with substance use problems. And so if we treat it sort of as something that everybody's at risk at, and so everybody who's coming into either, in a correctional facility or anybody who's coming into healthcare, we routinely screen everybody. It becomes less stigmatizing. And so these are some of the standard screens we encourage people to use, either to look at alcohol use disorder or opioid use disorder. Mm-hmm.
Do people still use CAGE?
CAGE can be a helpful way to start a conversation. It's an interesting one because it's 4 questions and it's used in the last year too. So I've often had people who've said yes, but they're actually been sober for 6 months too. And so some of these are more like in the last 2 weeks. That's a little bit more immediate risk. Again, most healthcare providers were trying to use more controlled medicine agreements. So if we're using medications that are at risk for diversion or dependence, to do controlled medicine agreements. So really they sign a contract and say, okay, I'm going to come, once a month or every couple months to see you. I won't get prescriptions from outside providers. I will agree to have my urine tested every 2 months. And it's effective actually for the person to make that commitment and then to write it in. And it also helps the provider know what to do if somebody's had a relapse too. So it kind of gives you a plan going forward. Again, I mentioned the prescription monitoring program. So this is a web-based system. And what it does is, so if you have a DEA number, so if you're a clinician who's authorized to prescribe medication, you are allowed to access this database. And so I can type in my patient's name and their date of birth, and then it will pull up every controlled prescription that they've had. So it'll all pull up the prescriptions that I prescribed. It'll also, it can link, I think, to about 12 or 15 different states in New Mexico. So I can also see if they're receiving prescriptions outside of the state. I can also look and see, gosh, I prescribed that one, and then they went to, this ER and they received this medication. And so then it opens a conversation. I also, if I have a controlled substance use agreement with somebody that I'm prescribing buprenorphine to, and our agreement is that that person won't take a benzo or won't be prescribed a benzo, I need to check this regularly. And again, if a prescription comes up under their name, it's an opening for a conversation and then a discussion about whether or not treatments, if they're really wanting treatment at this time. Again, urine tox screen is actually a good part of best practice too, so it's helpful as initial screen. And it helps us both make sure, find out what somebody's using. But again, it comes to that question too. If I'm prescribing something and it's not in their urine, that makes me worry about diversion too. So are they selling my prescription? And so I actually expect, if I'm prescribing something like a benzodiazepine, I expect that to be in their urine. And so doing routine drug screens is also helpful clinically to kind of keep having that conversation about how sobriety is going, how is your medication use going, and knowing that you expect the controlled substances to be in their urine. And so now there's a lot more random tests that you can do in office too, so you don't have to send things out. So where to do them, each clinician can kind of decide, do they want to send them out to a lab, or do they have facilities to do on site? And then again, as we mentioned, buprenorphine and methadone are not in your kind of routine screens. So the routine screens that most primary care physicians will buy won't have buprenorphine or methadone. But it depends on, again, what screens people are using, because you can purchase screens with all the different medications. We've not talked about benzodiazepines, but things like Xanax, Valium. These are medications that can be used for treating anxiety, but they're very dangerous if you're taking these and buprenorphine or methadone. And so also kind of screening for these and making an agreement with the person about not taking these medications when you're either taking opioids or other other opioid replacement treatments. So again, this is kind of going to your question of kind of what's good practice for therapy. So cognitive behavioral therapy, contingency management is actually an interesting model too. So there's good data for this. So for folks who are really actually sometimes mandated into treatment and have low kind of an internal desire to stop using substances, you can actually have these contingency management groups. And there's really good data that these are effective in helping people really have good outcomes. So what happens is you come every week, and then you pick a raffle ticket out of a bowl, and you get a urine drug screen. So if your urine drug screen is clean, you get to pick a raffle ticket. And then everybody, you can get a variety of prizes. So if you have a clean urine, you can get a transistor radio or a voucher to McDonald's or a gift certificate.
A real transistor radio?
Whatever.
Wow.
but
no one will use again.
But so people are rewarded for having clean urines. And so it's actually a really nice, nice way for folks who maybe have some low motivation, but are maybe mandated to treatment, having, again, contingency management versus just talk therapy. Contingency management actually is associated with really strong outcomes and improved substance use outcomes. Community reinforcement approach is also nice because it's working with kind of family and social supports. 12 steps, either 12-step, like NAAA, is that? Maybe try to take two. That might be hard. And I'm thinking kind of about some of the folks that are homeless that we're working with too. Actually, transistor radio is a pretty prized object. Yeah. And it's cheap for these nonprofit clinics to offer. Matrix model is another intensive outpatient treatment model that we offer a lot in New Mexico too, where you go maybe 3 times a week and you do some group and you do some individual. And that is the end.